Okay, so I don't know whether I should say good night to all of you. Of course, the time is like that. Uh, so this is a class that Sanket asked me to do a long time ago. And I was thinking that probably it's very important because these days we all begin with investigations and then look at the patient. And history taking has become, like something on the side. So that's why I think that uh, this class is important for all of us. And I will just try to share my experience with history taking and why it is so important even in this age and time. Okay. Please note that this is an interactive class and you'll have to solve the cases that I put up and you'll have to keep answering on the chat box. Only then this is going to work for us. And I just put this up. What's the definition of a straight line? Can somebody tell me what's the definition of a straight line? Anybody? In mathematics, how do you define a straight line? Nobody is in. Okay. Somebody is answered. Okay. Has a beginning and an end. I can put 10 curves in the middle between the beginning and the end. And the line that connect two distant points in space, line with no curve. No. Two endpoints. It is the shortest distance between 2 points. Okay, that's a straight line. It's the shortest distance between 2 points. That's how we define in mathematics a straight line. Why I put this up is, if this is the beginning of the patient, it's the beginning of the history, and then you're going to the diagnosis here, a good physician is someone who goes in a straight line, who goes to the shortest distance between the beginning of the case and the diagnosis. So that refinement will come only when you take a good history and you do a good examination, only then that will come. So that's why I put this up as this being a good physician. This is the beginning of the case. This is the diagnosis. He goes in a straight line. He doesn't wander here, there, everywhere. And that is the shortest distance. Okay. So having said that, let me just move on. In this class, we will talk about why do we need to take a history? What are the components of the history that we should focus on? What is the importance of each component? How do we develop the skill? And lastly, we'll try to ask ourselves, will history taking survive technology? Because technology has come up in a big way. Will it survive technology? Okay, right. This whole class will be in the form of stories. There will be only cases which are presented and some explanations will be given. Each of those cases will teach us something, and that's why I have put it up. And that's why I said you should be interactive. So why take a history? Why take a history? The answer is for us to understand who is your patient, because the approach to that patient is totally different. Now I'm going to put up this problem. What is the drug you would start for type 2 diabetic patients? A1C is 8.5. One of them is a 35-year-old homemaker with diabetes. The other one is a 35-year-old salesman with diabetes. Both have an A1C of 8.5. So what drug would you put the homemaker and what drug would you put the salesman on? Can you answer, please? Yeah. Major meal of the day. Okay. Okay, that's one consideration. What else? What else? What else are you worried about when you start a patient? What is the weight? Okay, right? But I don't think being a homemaker and being a salesman, the weight will change, isn't it? Okay, somebody said hypoglycemia. Yes, correct, isn't it? We have to worry about hypoglycemia and the salesman because that man will be going from place to place, and many people who are having jobs like that, which make them not being able to access food at the right time. So, like we all have, even doctors for that, for an example, postgraduates, you will not be able to get food at the right time. You won't be eating at the same time every day, and you won't be able to access food at all. So the salesman who's walking around is definitely at a danger of hypoglycemia. And even if you put him on a drug that causes hypoglycemia, you should be warned. You should be told that you can get hypoglycemia. These are your symptoms. So what are the drugs that you could use in the salesman? What are the drugs that you could use in the salesman? Go on. Okay, you could use a metformin. What else? What else can you use? What else? A gliptin, correct, isn't it? A gliptin, a metformin, okay, or even dapagliflozin, things like that, which don't cause immediate hypo. What you're worried about is the sulfonylureas. So whenever you want to talk about any patient, then you should know who is your patient. So for the same disease, for the same level of A1C, unless you know what is the background of your patient, you cannot really choose the right drug. So that is why you have to take a history to understand who is your patient, what is his uh, social setup, what is his routine, how is he going to manage the routine. And if you're starting a drug, for example, for something like diabetes, definitely you should know your patient. So that's the reason why we take a history, right? Okay. Now I want to tell you an experience that I had when I was in Manipal. I used to run this uh, a training program for type 1 diabetes, and I used to have a lot of kids, young people coming from rural areas who are coming and taking treatment from us as part of an ICMR Young Diabetes Registry. So sometimes I used to see these type 1 patients who were taking, we used to subsidize the insulin because we had some funds, and we used to give them insulin. And after giving them insulin also, I used to find that the sugar was very high in some patients. And if you ask them, they say they're 100% compliant. Somebody wrote for the previous problem, is there a compliance or not? So this person would say, I am definitely compliant. I'm taking my insulin, but the sugars are high. What would you think of? How would you manage? What will be your approach to this patient? Type 1 diabetes patient, you are giving him insulin, he doesn't have a money problem. He's taking his insulin, sugars are tremendously high. What should you think of? What history would you ask? They're all young people. They're not having, renal failure or anything like that. They're all young people. They're all rural. They used to come to me from rural areas. So what will you ask for? Okay. Change the site, ask to demonstrate the technique, right method. Uh, Talking about lipodystrophy. Correct. Correct. Storage. True. Isn't it? So look at where the history is important to you. These are the steps of insulin, right? And if you don't ask, for example, many of my patients, that's when I realized in Manipal that many of my patients did not have a fridge at all in their house. So if they're not, I had one postgraduate of mine in a busy OPD, he came back and told me, Madam, this patient is storing the insulin between clothes in a cupboard, thinking that that's probably the coolest place in the house. Otherwise, we tell them to use a pot and put water in it and put the insulin in one dabba or something and leave it there so that it's not exposed to warmth and light. That's what we used to tell. So storage. Then you have to instruct them to keep the insulin outside for half an hour. Otherwise, the cold insulin will be painful and patients will resist taking it. They have to roll, isn't it? You teach them to roll the insulin in their hands. You have to match the syringe and vial. Sometimes I used to see people who are taking 100 units insulin, 1 ml, they used to use 40 units syringe and the other way around. The side change which you all mentioned is very important. And please ask patients to demonstrate where is the site they are taking. And you can see here the lipodystrophy in a patient. And this one patient I saw was a pathologist's mother. It's not that she was, uneducated or anything. But the point is that sugar was never controlled. And she was an educated woman, and I think nobody inspected the site where she was taking the insulin. She happened to take it in the abdomen. And once I said, I want to see where you give your insulin, that's when I found that there was so much of lipodystrophy and lipoatrophy there that the thing was not going in at all. Okay. So the site change is very important. The technique is important, and the needle change. Many of my patients who cannot afford insulin never used to change the needle, and the needle used to get bent, won't go, and the insulin won't be delivered. Now, if you don't take a history, okay, and okay, now your sugar is 300. Let me increase. Let me put the mixed start as 10 more units. Let me put the regular insulin more, or put the basal insulin more. If you keep on doing like this, we're completely missing the bus, because we are not understanding what are the things that can go wrong with insulin. So that is why the history in any patient who's on insulin is very, very important. Okay. Now, coming on to the age. Okay. Uh, what is the target BP of a 75-year-old man with diabetes, hypertension, and old CVA, and the target BP in a 40-year-old man with diabetes and hypertension? How do you answer that? What's the target BP in an older person? What's the target BP in a younger person? Yes? Anybody? For a 75-year-old man, what are you worried about when you treat the BP? Okay? 150 by 90 in an older person, 140 by 90 in a younger person. People are giving me cutoffs. Yeah. Okay. Somebody saying 140 by 90 and 130 by 70. Right. Okay. Now, what you have to understand is, what are you worried about in the old man? The 75-year-old man, when you're treating his BP, what are you worried about? Orthostatic hypotension. Correct. You're worried about a partial hypotension, right? So uh, you're also worried about the diastolic BP, right? He's got an ischemic heart disease here. You don't want the diastolic BP to go below 70. If it goes below 70, these coronaries will not perfuse, right? So you have to worry about this old man, and that's why the age of the patient is very important, because who is the patient you're treating will completely change the way you look at the disease and what drug you will give. Whereas in a younger person, yeah, you could probably use a drug that acts against the sympathetic system, because the sympathetic system will be quite active in a younger person. So a beta blocker or an ACE inhibitor may take precedence over the other drugs. But anyway, whatever it is, you can be more aggressive in this person. Whereas in this man, you have to worry about, like what you said, partial hypotension, and then falls, etc., etc. Okay. So age does matter, right? Okay. Okay. Look at this problem. Diarrhea and abdominal pain for 6 months in a 35-year-old lady. Diarrhea and abdominal pain for 3 months in a 68-year-old man. What's the difference in the diagnosis? Diarrhea and abdominal pain, 6 months, 35-year-old lady. Diarrhea and abdominal pain for 3 months in a 68-year-old man. What would be your diagnosis for this? What would be your diagnosis for this? Yeah. Malignancy in the older age group. Okay. A recent change in bowel habits in the elderly, you always have to worry about a malignancy. Whereas in a younger person, this lady is having a diarrhea, but she's got abdominal pain, but it's gone on for 6 months. You should definitely ask other questions. I'm not saying you just base your diagnosis on these 2 lines that I've given you, but you should think, what is there a weight loss, what are the other is there blood in stools, etc., etc., should be asked for these patients. But see, the thing what I made is, I just changed the age for the same symptoms. I just changed the age, and age makes a huge difference to the diagnosis and also to the treatment of anybody. Okay, so that's why age matters. So when you're taking a history, you're asking the patient, who are you, what is your name, what is your age, okay, what do you do, what is your background. That's how you proceed, isn't it? But each of them has to be taken into account when you're finally treating the patient. Of course, sex matters, isn't it? What are the diseases which are more common in women? What are the diseases more common in men? It's a standard Viva question, isn't it? When people are getting bored towards the end of the exam, such questions will come up. What are the diseases more common in women? Okay, thyroid in women. Okay, SLA in women. Okay, go on. Go on. Any other diseases in women? Any autoimmune disease, isn't it? Why only this? Any autoimmune disease is much more common. Mitral stenosis is more common in women. ASD is more common in women. MVP is more common in women. You can go on. There are so many diseases which are much more common in women than in men. Okay. Whereas aortic valve disease is more common in men. What are the diseases common in men? Men. Nobody is talking about the men at all. What diseases are common in men? Okay. CA lung, not always. Okay. Hypertension to some extent, yes. Ischemic heart disease to some extent. Spondyloarthritis, isn't it? Gout, correct. So you see that when you're looking at a patient, when you're talking about what is the sex of the patient, then these things come into matter. Okay. So the age of the patient is important. The sex of the patient is also very important to you because some diseases are more common in women, some are more common in men. Then we go on to the components of history. Now, your usual components of history, you must have learned as an undergraduate. So I'm not going to, talk too much about it, but let's just bring few points up. 36-year-old man is brought with fever of 3 days duration. He also complains of uh, vomiting since 5 days. He has an upper abdominal pain since 1 week, following a meal at a temple function, and he has been nauseous since then. Okay. Now, when somebody asks you, what is the chief complaint here? What would you say? What is the chief complaint? This is the history. What is the chief complaint? Yeah? Fever. Okay? Right. Remember, you can, what is the definition of a chief complaint? How do you define what is the chief complaint? Or chief complaints, if you want? Anybody? How do you define that? It's a it's a complaint that prompts a patient to go to the hospital, right? That troubles him enough for him to come to the hospital. Now you can have one chief complaint, you can have more chief complaints. There's nothing wrong with that. Okay. Patient can be equally troubled by two different things, right? So first of all, you ask that. You ask that question, what brings you to the hospital? That's the beginning of your conversation of history. Like we teach in undergraduation, that is important. So this patient has fever of 3 days, vomiting since 5 days, upper abdominal pain since 1 week. So this upper abdominal pain was there, then the vomiting came, then he got a fever, etc. Okay. Now, the next thing that you ask is the duration. Okay. So if I'm giving you an example of how the duration will change the diagnosis. If you have a unilateral headache in a 35-year-old lady of 2 days, 2 weeks, 2 months, 2 years, what's your diagnosis? Unilateral headache in a 35-year-old lady of 2 days duration, 2 weeks duration, 2 months duration, and 2 years duration. How will it change? Again, these are questions that are asked for you in the exam. Suppose you say, okay, you're presenting a case, you're telling patient has had a headache for 2 months. Then examiner can always tell you, I want to change it. I'll say that the patient came with a history of 2 years headache. How will it make a difference to your diagnosis? So what would you say? Okay. Somebody is calling it giant cell arthritis. Okay. 35-year-old. Yeah. 2 days you'll have SAH. SAH is what is it? What is the characteristic of a SAH headache? What is the characteristic? Everybody, you cannot go and call them as subarachnoid hemorrhage. What is the characteristic of that? There are two characteristics of a SAH headache. Okay, it's called a thunderclap. Why it's called a thunderclap? Why is it called a thunderclap? What is the meaning of thunderclap? Okay, one is the worst headache in life. Second one is the suddenness, isn't it? The suddenness. It comes out of the blue, right? So patient is happy one moment, next moment he is sudden gone. That is called, that's why it's called the thunderclap headache and the severity. So just because I said unilateral headache in a 35-year-old lady, you can't immediately make a diagnosis of SH, okay? A 2 days headache will be what? Most probably a migraine, correct? Okay, 2 days unilateral headache, 35-year-old lady, she's a right age group to get a migraine. You have to ask whether there's a throbbing headache that's associated with vomiting, some nausea, some, you don't want noise, you don't want light, that kind of photophobia, phonophobia, all that you would think of for 2 days. If you extend it and make it 2 weeks, what will you think of? Unilateral headache in a 35-year-old lady of 2 weeks duration. 2 weeks duration will be what? Yeah? Anything? Anything? 2 weeks? You'll have to go for something that is okay. You have to go for something that's close there, right? You won't call it pregnancy for a headache, right? Okay. Yeah. 2 weeks duration will be something in the, you remember, headache is not only structures in the head, it's structures in the skull. So you can get, eye pain can cause headache, isn't it? Your sinusitis can cause headache. One ear pain can cause headache. One toothache can cause headache. Everything in the skull can cause a headache, right? Okay. Now to call it a meningitis, etc., I should have given you a fever, right? I'm not even given anything like a fever, so you really won't go near some kind of this thing. Okay. A 2 months headache is where your myopia, astigmatism, some of the more chronic things would come in. And a 2 years headache is definitely not a dangerous headache. The longer the duration, the less severe any causes. Okay. So that may be some other reason. Okay, right, fine. Okay. But we need not think of sinister causes all the time. Some simple causes also will be there. Of course, you can get a, Ixol, you can get an ICSOL, but it's not going to be that common. Okay. Remember that. But what I want to tell you is the same complaint, duration change will be completely different diagnosis. Okay. Now let's go on. Now I just want to tell you a story of how I realized the duration was very, very crucial. So we had this patient who was admitted with us, who was a 75-year-old man who came with a history of, was admitted in a previous hospital and came with some fever and all that and some diarrhea. He got better there, but he said that he was feeling very weak. And whenever we tried to ask the history from the patient's relative told he's deaf. So we thought, okay, he's deaf. And so every time we used to ask him, shout at him very loudly. And then we used to answer a few words. That's all. And we went on like this and we could never solve what he had. And all the time he was just very dull. He used to sleep off. He never used to talk. And he used to say, and the son used to say, he's deaf, he's deaf. Somebody one day asked him, how long has he been deaf? Okay. That one question, how long has he been deaf? And that elicited a very strange answer. The answer was that he's been deaf for 2 weeks. So 75-year-old man is been deaf only for 2 weeks. Okay. Now that was a shock, because why would he somebody become, and we asked, before that he was already, before that perfect. He was hearing everything. 2 weeks ago, he became deaf. 1 year, both years, he cannot hear a thing. Now that was so strange that why would, I mean, just like we say, bilateral sudden blindness is probably hysterical. So we have to think that bilateral sudden deafness is also probably something else. It doesn't look like organic. When we elicited the history, we got a strange, funny history. He was admitted in a previous hospital, and in that hospital, he was, for the diarrhea, somebody put him in an ICU. And he was sitting in the ICU, and that day happened to be a very busy day for the ICU staff. And what happened was, 2 people died in that ICU. On either side of him, 2 people died. When they died, this man was very scared. When he was very scared, after the next day, he said, I can't hear anything. So the son asked, why you can't hear anything? He didn't say. He said, I have become deaf. I can't hear anything. That's all. And when we probed, he explained to us that when these 2 people died on either side of him, he thought the Yamadutas, no, those who are the assistants of Yama, had come and told to the other 2 people that we are taking you. And they tried to tell him, we want to take you too. And then he said, I can't hear you, so I can't come with you. I didn't know what you said. This was his explanation. It is such a strange story. But what I want to tell you is that this was, if we had not asked this one thing as what is the duration, you would have never understood that this man was actually completely scared. Nothing else was wrong with him. So many times we assume somebody is old, is deaf. You don't realize that you must ask what is the duration. So when we elicit a complaint, the duration is very important. The next thing is the chronology. When we present the history, we always say, no, how many days, how many days, how many days. So I'm just giving you a chronology. You got a fever of 4 days ago, severe vomiting, weakness 1 day. The other side, vomiting 4 days, fever 4 days, weakness 1 day. What do you think will be the diagnosis here? What do you think? The same set of symptoms. I have not changed the symptoms. Okay. Same set of symptoms, but this has a different diagnosis. This has a different diagnosis. What do you think this is? Fever came 4 days ago, and then this man had vomiting of 2 days. Now he is weak. So what do you think happened? What do you think happened to this person? 4 days ago, fever was there. Now it is gone. Okay. That could be a hepatitis, isn't it? Because the fever went off, then the vomiting came in. Okay. The fever went off, and could be a dengue also. Correct. Sometimes when the dengue resolves, I mean, the fever goes down, that is when the platelet goes down, that's when the vomiting starts, that's when the serositis happens, etc. So this is a different, completely different diagnosis from this. Patient has vomiting for 4 days, fever for 4 days. This looks like some kind of an infection, right? Some infection which is causing fever and vomiting and weakness. So just the same chronology, I mean, same symptoms, different chronology, completely different diagnosis. Okay. I'm not given the age because every problem I can't give. Okay. Now I'm going to ask you to solve a few problems based on the chronology, just the chronology. So let me start with this problem. I'm sure you'll be able to give the diagnosis just with the history. 30-year-old lady comes with weakness in the legs since 2 days. Mother noticed that she has been struggling to get out of the dining chair since yesterday. Today, she felt she could not take food to her mouth and asked to be fed. Since this morning, she finds it difficult to breathe and can't complete sentences in one go. What's the diagnosis? Okay. So easy, right? So easy. Did you need any investigation for this? You did not even examine the patient, isn't it? You did not even examine the patient. Right from the history, that's because the history is given to you so easily. Patient may not tell you all this so nicely, but I made it very simple, simply with the chronology. It's an acute onset neurological deficit. First day she had legs, and then she had hands, then she can't breathe. So it's obviously going into a respiratory failure. 2 days onset, what can it be? It can be only a GBS, right? So this chronology and the presentation completely gives you the history. Now, going on to this thing, when we talk of history taking, we always say we must take every symptom to its logical conclusion. So if a patient says fever, patient says headache, patient says drowsiness, you have to analyze each of those complaints to their logical end. And you have to find an answer as to why you are getting this fever, why are you getting the headache, why are you getting the drowsiness. I think all of you know how to analyze the fever. It is low grade, high grade. High grade means acute bacterial infection. Low grade means some other bacteria, chronic infections like tuberculosis, etc. Fever with rigor is there. Fever is continuously there. Of course, we can all be modified by treatment. Then you are asking the systems. If nothing is there, then you're going for an acute febrile illness. You know all this, right? I'm not going to analyze it for you, but each symptom has to be analyzed to its logical conclusion. Something like a drowsiness will be much more difficult to analyze than a fever, because you have to ask the patient, how did this drowsiness start? Any CNS symptomatology has to be explained in terms of onset and mode of onset and progression. That's how you describe any CNS symptom. So the drowsiness came in. Did it come on suddenly? Did it come on, slowly, etc., etc.? That is very important, right? And from there you make a diagnosis. Headache is, of course, very non-specific. Can be from structures inside the head, outside the head, like what we said, and it can be severe, it can be mild, etc., etc. So I'm not going to the details, but each complaint has to be this. So let's look at one complaint. Suppose I tell you 30-year-old lady present with coughs of 2 weeks duration. What questions would you ask? Suppose the patient has cough. What are you going to ask? Quickly. Productive. Okay. Why are you asking whether it's productive or not? Why are you asking whether it's productive or not? A non-productive cough means what? A non-productive dry cough means what? Allergic. Okay. It tells you where in the respiratory system this cough is coming from. Correct. So if it is respiratory system, let's leave out the other things for the moment. But if it is respiratory system, a dry cough is coming from a non-productive area. Put it the other way around. When will you get sputum? Which parts of the respiratory system will cause sputum production? Where in the respiratory system you get sputum production? Lower respiratory tract, correct. So it has to be from the lower respiratory tract. An upper respiratory tract infection will not cause productive sputum. A pleural this thing will not cause. An interstitium will not cause. So it actually tells you the site of involvement of the respiratory system. Then you go outside. You can talk of GERD, you can talk of cardiac later. But your dry cough tells you that this is coming from an area where sputum is not capable of being produced. Okay. And if it is there, sputum is produced, then you ask what is the color, what is there hemoptysis, etc., etc. So again, the duration is 2 weeks. So it's a 2 weeks history. So definitely you have to think of, okay, you are asking allergy, but what else will you ask? What else will you ask apart from allergic cough? Every 2 weeks cough is not an allergic cough. We don't, yeah, correct. You have to ask for fever, weight loss, etc., etc. So the further questions that you ask, see, ultimately, all we have to remember is in any history taking, we are trying to get the diagnosis from the patient. So if he's saying cough, we find out, is it respiratory, non-respiratory? If it's respiratory, which part of the respiratory system is it coming from? And if there is a hemoptysis, then it becomes very narrow, right? Once a patient says hemoptysis, then you know, like what we used to say, that it has to be only one of the few causes. It has to be, tuberculosis, bronchiectasis, bronchogenic carcinoma, the few causes. So as you get more and more history, you are narrowing down and inching your way to the diagnosis. Everything that the patient gives you is a clue, right? So you have to ask definitely what is some positive history. But the negative history is also important. For example, look at this. 65-year-old lady is brought with loss of consciousness. Blood sugar is 45. What negative history is important? What history is important in this patient? She's 65-year-old lady. She's loss of, okay, you want to ask whether she's diabetic or not. Okay. Why you want to ask for fever? Seizures. Okay. Seizures. Okay. But first of all, yeah, correct. You want to know that she's on OHS, etc. But what is very odd, why this lady came with, okay, diet history, missing diet as the cause of hypoglycemia. Suppose I say she's diabetic, yes, whether she's on OHS causing hypoglycemia or insulin. But what is here is this one, 45 milligrams, loss of consciousness. So what's important to you? What is this called? What is this called? 45 milligrams and loss of consciousness. So what's odd about this now? What is odd about this? Neuroglycopenia, correct. Neuroglycopenia. So what are you worried about? If somebody is, 65-year-old lady has got neuroglycopenia, what are you worried about? Yeah. Why she went directly into neuroglycopenia? That means what has happened to her? What has happened to this lady? Why she's not? Seizure is a consequence. I'm asking you why she did not complain. Why she went directly here? Okay, autonomic neuropathy, isn't it? Hypoglycemic unawareness. That's what you have to worry about. So you have to ask for negative. You have to ask whether in the previous past also, whether she had, repeated attacks of hypoglycemia, which she did not know, or she's been, regularly eating some sweet and getting out. So there may be, this is a very dangerous thing, right? She did not have any warning symptoms of hypoglycemia. So this person, it is impaired awareness of hypoglycemia, right? IH is what you call it. Hypoglycemic unawareness is what you call it. And repeated episodes of hypoglycemia can lead on to hypoglycemic unawareness. Correct? So, and autonomic neuropathy can cause hypoglycemic unawareness, or beta blockers can cause. So again, the negative history is as important as the positive history. So the history keeps on changing based on the knowledge of the subject. So many times when you're undergraduate, it's very difficult when they say, okay, CNS, you ask all this, CVS, you ask all this. In real life, we don't do that. We are asking from what we understand from this patient. Based on that is how we ask the next few questions. So we are inching our way to the diagnosis. And this is very important because this patient's next hypoglycemia can be disastrous, right? She may go into hypoglycemic coma from which she may not recover. So that's why the drugs that she's on, how do you adjust it, what meals she took, and how to tell her and to avoid hypoglycemia for some time. Sometimes it can be a functional autonomic failure, what you call as half hypoglycemia associated autonomic failure, which is more common in type 1 diabetes. It's important. correct? So if that is there, then it's very important to avoid hyperglycemia for the next 2 to 4 weeks, so that the autonomic failure, which is a functional problem, recovers and the autonomic system is able to make out hyperglycemia. So much of thought will have to go in with the negative history. You understand that? So that's why we said positive and negative history is important. Now look at this problem. Another example of why positive and negative history is important. 50-year-old man is being treated for anemia for a hemoglobin of 7 grams with iron tablets. After 2 months, I'm sorry, I changed the sex here. This patient's hemoglobin is 6.5. What history would you ask? So he's 50 years old. He's found to bear hemoglobin of this thing. Okay, we ask for compliance. He's compliant. He's taking drugs. Okay, we're asking for blood loss. Correct? Correct. What else? Timing of tablet intake. Okay. Oh, you're talking about the tea and all that stuff or an empty stomach. Those are all minor things that won't drop the hemoglobin, right? Okay. Okay. Untreated worm infestation. Okay. Then what else? Okay. Hemolysis. So you see, this is this is anemia which is not responding to iron tablet, isn't it? It can be something else also, right? So again, what history you're going to ask depends upon your knowledge. Okay, like what we say, is she taking tablets? Is she having an intolerance? Is there an blood loss? Weight loss suggests malignancy. Is the diagnosis right? Is there a B12? So many times in our hospital also, we see people who are treated with iron all the time and they don't get better at all. And people don't understand that it could be something else which is causing the anemia, not the iron. Okay. So look for a B12, look for hemolysis, look for a CKD, isn't it? Sometimes a chronic kidney disease, nobody does a creatinine. That could be the problem, or a marrow issue. So the whole diagnosis must be wrong. So all your questions in this history are because you're thinking of something. Okay, so when you saw this problem, you had some possibilities in your mind. If you don't have those possibilities in your mind, you can't ask these questions. Okay, so questions towards the diagnosis are asked keeping in mind what are the possibilities. Based on that is how you go. I'm not asking reti count and all. I'm asking only history. I'm just going to ask only history and then think. Okay, so for a B12, I'll ask if the patient is a vegetarian. For a hemolysis, I'll ask if the patient has jaundice. For a CKD, I'll ask for hypertension and edema. For a marrow issue, I'll ask for fever and a bleeding tendency. Okay, that's what I'm saying. So unless you know this background, it's not possible to take a good history in that problem. Okay, so when we take history, this is how we analyze. The history of presenting illness, analyze each complaint to its logical conclusion. Then ask for relevant positive history, ask for relevant negative history. Then two more things we add. Questions towards etiology. For example, this iron deficiency anemia which is not responding. Is it the person losing blood, or the whole etiology is different? And questions towards complications like 6.5. Okay, are you breathless on walking? Do you have, chest pain on walking? Are you in failure, etc., etc.? So these are the 5 things that we always say. Each complaint to its logical conclusion. Ask for negative history, positive history, negative history, questions towards etiology. So you're going back, and questions toward complications, which is going forward. Okay, right. Now let's look at the next problem. Whenever we take a history, okay, even in the exam, you are asking no history of, sometimes people will go on telling some 20 no history of this, no history of vomiting, no history of diarrhea, no history of headache. People call it systems review and they go on asking. But if you do not know what the answer should be, for example, you are asking, is there a history of vomiting? If the answer is yes, what's the diagnosis? Where will you go? If the answer is no, no vomiting, what will you think of? If you don't know if this and this, you don't know what it means, don't ask that question. That question is completely irrelevant, right? So it's like a cross-examination. In a cross-examination, a lawyer always knows what the answer should be. Knowing that answer only is asking that question. So always remember that when you're taking a history also, it's like cross-examining a patient and trying to come to a diagnosis. So when he says yes, you go in one direction. When he says no, you go in another direction. If you don't know that the answer to yes or no, where it leads to, don't ask that question. Okay. Let's look at past history. Okay. For example, 67-year-old diabetic presents with atrial fibrillation. What past history do you want to ask here? What past history do you want to ask here? This patient presents with atrial fibrillation. What do you want to ask? Okay, you want to ask for a TIA, correct? You want to ask for a CVA? Want? Okay, how long? I mean, he doesn't know how long he has had palpitation. You can ask. What else will you ask? The cardiac failure, right? Is he got IHD? What is the cause of the atrial fibrillation? What are the complications of the atrial fibrillation? Both you will ask, isn't it? Both you will ask. That's what I said. We're asking for the cause, we're asking for the complications. Both sides you should go. You should go back and you should go forward. Okay, so that's it. In a cirrhosis patient, what past history you want to know? Patient cirrhosis, what past history do you want to know? Again, questions towards etiology, questions towards complications. You remember that way, it's much easier, right? What are the manifestations of cirrhosis? Ascites is there, period edema is there, this thing is there, hematemesis is there, hepatic encephalopathy, has he ever been in hepatic encephalopathy, etc., etc., etc. And then you go for the past. The recurrent UTI patient, what do you want to know? Recurrent UTI patient, what do you want to know? You want to ask about obstructive symptoms, isn't it? Something in the tract which is not preventing the infection from healing, or something in the host which is making him susceptible to infection, or something in the host which is making the infection recurrent. Okay, that's all. Any recurrent problem, you have to think either the tract is abnormal or the host is abnormal. So that's how you will ask for the past history. So everything changes depending on what is your diagnosis. Okay, this is case which Sanket was discussing with me a few days earlier. So he was telling me he saw a 20-year-old male and coming with joint pains, and the age of the patient, age of onset was 18 months, and patient was being treated as a rheumatological problem because he had swelling of the elbow and joint, and intermittent and episodes were there, and there was a high CRP. So what's odd to call this a rheumatological problem? What is the odd thing here? What is the odd thing here in this problem? Yeah, the age, correct. The age of the patient. The age of the patient is so small, this thing in 18 months, what rheumatological problem is going to get? And that's when Sanket told me that he asked for this history. Patient's maternal uncle had similar complaints. What's the diagnosis? Okay, what's the diagnosis? Yeah, hemophilia, correct, isn't it? It's an X-linked disorder. So you're asking for the mother's family, a man, correct? So that's the uncle. So Sanket told me that he made a diagnosis in one shot, whereas the patient had gone to different rheumatologists, and each of them had given different diagnosis, and he was also on disease-modifying agents, etc., etc. So see how the carefulness of the age of onset and a little more care regarding the family history gives you the diagnosis. Several diseases you can diagnose based on the family history like that. Of course, you know all the inheritances.
Yes, ma'am. I'll just tell about this patient that
Sure.
perfectly, he's a 20-year-old boy and who has knee and elbow swelling. It was intermittent pain, and every time pain CRP was high and all, and he was on methotrexate and HCQ. Now, see I think the part what like we initially feel excited to make such a diagnosis in one shot, but that day I was sad and I had to discuss this key. This was seen by 17 doctors. Okay, it's not like something I did magic here.
Yeah.
It was the history. I just asked that what else. 18 months was already irritating me that it's not something my disease start there. So that was thing that, and father told very clearly that 1.5 year back, he fell down and it was very difficult to control bleed.
Right.
So that was again a very good clue that if we ask patient, because see what happens, like patient does take us as a joint doctor many of the time, orthopedic or rheumatologist, that we have to tell just joint issue to this guy, nothing else. Specifically skin problem, they will never tell us about psoriasis. So any joint pain we see, psoriasis, they think it's a skin problem. So the making diagnosis of psoriatic arthritis and rheumatoid arthritis becomes quite different because management is different. So it's very important, I think, that this case, I still like seeing that. I ordered just one test, APTT. It came prolonged and I was pretty sure, now I am on the right track and this has to be factor supplemented. So family history, if you have habit of making that chart pedigree, it solves cases because we are putting active effort. Asking is a good habit, but documenting is another way to do it.
Correct.
Yeah.
But
Yes.
I was very impressed with that case because, see, some simple things, if you are just alert, we can probably make a diagnosis without going for too many, investigations or whatever, right? And it's a lack of that makes the diagnosis missed.
Yeah.
Okay, now look at this. 26-year-old lady comes with diabetes. What history is important in her? 26-year-old. In the context of family history, what would you ask? Why are we interested in this 26-year-old who comes with this thing? Anybody? Yeah. Okay. So you're thinking of a Modi. So what history is important in her? What history is important in her? It's a tri-generational family history, isn't it? I think you had a very good class on Modi by an endocrinologist. I was listening in Medcast only. So you explained so well the different types of Modi, etc. So the tri-generational family history. So when you're seeing a 26-year-old lady who looks to you like type 2 diabetes, not type 1, she is well controlled on a small dose of OHA, then the tri-generational family history. But the point is the tri-generational family history also, sometimes the father or the grandfather or whoever, mother, grandmother, whoever it is, may have such mild diabetes that they might have walked through life without much detection. Okay, because again, it's a fasting sugar that's slightly high, some 140, 150, like that. The postprandial may even be normal, A1C borderline. The father may not have been even diagnosed like that. The other thing is somebody told sibling. It's not only the sibling, okay, it's Modi is not about the sibling. The point is what we call as genetic anticipation. Like, when I came to Chennai, I realized that the whole population here has so much diabetes that when a generation of say your father or mother, that generation somebody has diabetes at the age of say 46, the son or the daughter is likely to get at 36. So one decade earlier the disease is preponed. So that's why it's important to ask parents also what is their history. Could be a young onset diabetes also. It's an early onset type 2 DM also is possible, right? Apart from Modi. So again, based on the patient, we have to ask for the family history. Menstrual history is again important. Suppose this is all very simple things I put up. 55-year-old lady with palpitations and sweating probably has a menopausal symptoms. 30-year-old lady with anemia has probably a menorrhagia. 15-year-old with lower abdominal pain could be either dysmenorrhea or even a mid-cycle pain, etc. Now, when you say about pregnancy, okay, most often we all ignore pregnancy, but there are many pregnancy-related medical diseases that we should think of. So what are those pregnancy-related medical diseases? Can you list? Which diseases are common or associated with pregnancy? Not common. One I put up. I didn't want you to say GDM, so I've already put up. So what else can you think of? Okay. Hypothyroidism, polycystic of pregnancy. Go on. Go on. Eclampsia. Eclampsia more of I'm asking you medical disorders. Okay. Gestational thrombocytopenia. Correct. Like that. Any more? It's also about gestational thyrotoxicosis, isn't it? Associated with twin pregnancy, multiple pregnancy, hyperemesis gravidorum. So there are so many diseases that are associated. I just put up whatever I suddenly remembered. Okay. So cortical vein thrombosis, gestational thyrotoxicosis, gestational thrombocytopenia, acute fatty liver of pregnancy, which can be even fatal, right? Cholecystectomy, benign cholecystectomy of pregnancy. And of course, PRES, correct. PRES can occur, right? So there are so many diseases which are related to pregnancy that can come. Okay, fine. So now you should also review the drugs. If a patient is going to get pregnant, then whatever drugs you're on, hypertension, diabetes, you all have to review the drugs, especially if they're planning pregnancy or they are already pregnant. What are the drugs you should come out of? For example, ACE inhibitors you cannot give, beta blockers you don't want to give. You don't want to give much of sulfonylurea, so not very unsafe. You don't want to give a gliptin, things like that. Okay, so whatever drugs the patient is on, so that is why it's important to ask about the menstrual cycle. Smoking, we all know, we are all, and especially alcohol in this space, there's so much of alcohol. That is why, this is important. The point is that people do not accept this. So many times it's good for you to ask instead of saying, do you smoke? You always can ask, when did you stop smoking? Then they will tell you 1 week. That means he's been smoking for 40 years. That's how it is. And whatever he says, if he says he's drunk alcohol for 2 years, you have to immediately multiply by 3 or 4 for you to get the correct number of years that he has had alcohol. And of course, appetite and weight, you all know the difference that if they go together, they are in favor of a malignancy or a tuberculosis. If they are disconnected, then it is diabetes, thyrotoxicosis, malabsorption. That's how it will go. Bowel and bladder symptoms, of course, are important in various conditions. So I won't elaborate on that. Now, sleep and stress is something that you all miss. Nowadays, I taught myself to write it on the side of the history, that when we take a history, on the side, I write diabetes, hypertension, smoking, alcohol, sleep and stress. And then whether the patient is vegetarian, few things I write on the side. So the sleep and stress is something that we completely miss. People do not ask. I still remember how I hurt one patient whom I still regret. I shouted at her for not controlling the diabetes without understanding that she had a major family tragedy just a month ago. So, her sugar was right out of control, but this lady was so much under stress that sugar would have gone out of control. 35-year-old lady with palpitation and syncope is probably having a panic attack. 16-year-old lady with convulsions before exam is a stress-induced convulsion or an epilepsy. Extreme tiredness and insomnia could be depression, could be hypothyroidism, whatever. But please remember that when you are asking the history, this diabetes, hypertension, smoking, alcohol, sleep and stress, and appetite and weight, some 10 things I usually write down on the side. Make it a habit so that you don't miss any of them, because sometimes in a hurried case sheet, you miss. Okay. Now let's look at this problem. Again, diagnose from the history. Just look at the hidden clue here. 70-year-old hypertension has been feeling weak since 1 week. She has started on additional medication for uncontrolled hypertension 2 weeks ago. She feels she's unable to do any work and wants to sleep. She's in emergency with altered sensorium. No fever, no breathlessness, no chest pain. What would you think of? What would you think of? Many times we see patients like this. Yeah? Okay. Which diuretic? Can't say diuretics. Which diuretic? Which diuretic causing hyponatremia? Thiazide, isn't it? Furosemide hardly causes hyponatremia. Please remember that. It's a thiazide that causes hyponatremia. And many times, because the Western guidelines say that a 70-year-old, the thiazide is the best drug, all your guidelines will tell you. But I am rather convinced that at least in Chennai, I don't start thiazide for anybody because we sweat so much here. Hyponatremia is very common. Almost in a month, 2 or 3 people I am seeing with hyponatremia, and many of them have a thiazide on the side. So again, comes from the history only. You can make a diagnosis because there is a history of starting hypertensive medication 2 weeks ago. Okay, so that's a thiazide-induced hyponatremia. In the treatment history, again, very, very important to document it. In diabetes, you want to know what drugs the patient is on, is a complaint, are they taking at the right time. Many times people do not know that they have to take before food or after food, not explained to them. In tuberculosis, we are asking about ATT-induced hepatitis, etc., etc. In COPD, many times I found that patient is not taking inhalers correctly. They don't know the technique or they're not using it. And many times people get fed up of the BiPAP machine, which we prescribe whenever the patient comes with type 2 respiratory failure. So you tell them to do an overnight BiPAP. All of them do 4 hours, 2 hours, and then they stop it. And you slowly see the carbon dioxide rising. Again, in hypertension, there are many drugs which hypertension, and many of them, you know, that all of them can have side effects. So you have to go monitor your potassium, to monitor all those things. So treatment history is again very, very important. Now I'll just do a small exercise with you. So 30-year-old patient comes with jaundice of 2 weeks duration. What is the quickest way to come to this diagnosis? What are the questions you want to ask? 2 questions you would ask in any patient with jaundice. What are you going to ask? 2 questions. Any patient with jaundice. Color of urine and fever, everybody wants to ask. Anything else? Stool. 2 questions are color of urine and color of stool. Okay. If the urine is high color, normal colored, then it's a hemolytic anemia. It's an echoloric jaundice. So if urine is high colored, it's probably cholestatic or it could be hepatitis. Hepatic, not hepatitis. And from that, you take which of them has a pale colored stool. If a pale colored stool, then you go towards the cholestatic jaundice. Not pale colored stool. Normal colored stools are and a high colored urine is probably hepatic. So the two questions that you ask in any patient with jaundice are color of urine, color of stool. Get your type of uh, jaundice clear first. After that, okay, you're thinking of cholestasis, then you ask about itching, then you ask about gallstones, you ask about CA pancreas, go that side. If you're thinking of a hepatic cause, then you go towards cirrhosis, then you go towards liver, etc., etc. Okay, so the shortest way to reach a diagnosis is this, but please understand sometimes patient will not tell you correctly what is the color. Okay, after that, suppose you're thinking of hepatitis, then of course this outside food, this blood transfusion, okay, all those things should be asked for the etiology. And of course, what you are vomiting, or you're having a weakness, is the patient getting tired, those things for hepatitis and cirrhosis. So easy way of analyzing every symptom, there must be one pattern that you must use, then it's easy for you to make out. Okay, so history taking is an art. Lot of experience is needed before you take a good history, but the point is it's actually simple. I will show you why. Many times patient you come and residents come and complain, patient does not give proper history. Always the patient, he won't tell anything, madam. Whatever he asks, something he is telling. The point is the patient did not read Harrison. Please remember that. So he's not going to tell you, I had dyspnea, I had PND, I had orthopnea, I had great. He's not going to tell you any of that because patient does not know what you want him to do. Neither does the disease. Many times my professor used to tell me, why we are getting in tuberculosis, why we are not getting fever. Then my professor used to tell me that disease did not read Harrison. That is why it doesn't have fever. So please remember that every patient is different and every disease is different. So that's the challenge. Otherwise, what is the point in history taking, etc.? So know how to ask. That is why the patient is not telling you. It is said that the average American physician interrupts a patient every 14 seconds. This is another thing that we must remember as postgraduates. Many times, before the patient can complete one sentence, you have asked him 10 questions and he has forgotten what he wanted to tell you. So always ask an open-ended question. So he wants to talk, let him talk. Let him talk, listen to that paragraph, let him say whatever he wants. He may be meandering, he may be telling all kinds of things. He may be saying, I went there, I went here, whatever it is. Just listen. Because if you keep on interrupting, even if I keep on, for example, in the MD exam, why do you get flustered? Because the examiner keeps on shooting questions at you. You lose your train of thought, isn't it? Same thing you're doing to the patient. You keep on asking him 10 questions. He doesn't remember at all what he wants to complain about. And then in the end, he will tell you some very important clue. That time you'll shout at him. You'll say, why didn't you tell me this before? That is because you never allowed him. So remember to ask open-ended questions and listen to that paragraph. The art of listening is gone because we are all in fast-forward mode. One of the best books that I ever read is Sapiens. And when I was listening to Yuval Noah Harari, the one thing that he says is our attention span has gone down with modern age. So we cannot even concentrate on anything. He said he's a big fan of Vipassana meditation. So he said, I could not watch my breath for 10 seconds. When they asked him to sit down and meditate, 10 seconds he could not hold attention. This is what has happened to all of us. That is why when the patient is telling history, we're not even listening correctly. We are thinking of something else. Now, people ask, how do you develop the skill of history taking? How do you learn cycling? By cycling, isn't it? So how do you learn history taking? By taking more histories, by listening to more people, by writing down. That's how you take. Now, the last part, will history taking survive technology? I want to demonstrate to you why it will survive technology. Now let's check this out, okay? So I want you to again answer these questions. These are all questions based on histories only, and I will tell you why I'm saying that history taking will survive technology. I wanted to answer in the chat box, fastest finger first, okay? 65-year-old clerk had gone to the bank to withdraw money. When he was talking to the manager, he felt headache on the right temple and wanted to vomit. He said he has forgotten to take his BP and sugar tablets that day. Headache increased, he collapsed, lost consciousness in a few minutes. Manager mentioned by helping him to the wash basin, he noticed the patient was dragging his right leg and could not reach the hold the wash basin with his hand. So what's the diagnosis? Okay, ICH, right? How much time did you take to make the diagnosis? How much time? Hardly 10 seconds, isn't it? Because where is the ICH? I'll make you say more. Where is the ICH? Where is the integrated bleed? Oh, it's the putamen. How do you know putamen? How do you know putamen? Thalamus. Okay. The commonest site, isn't it? The commonest site of a hypertensive bleed is that. Right. That's why you're saying that. If you have a lobar bleed in a hypertension, you'd probably think of a different cause. You think of an AVM or an aneurysm, isn't it? You don't get a lobar bleed in a hypertension. You think it's a last priority. You go for a putamen, thalamus, pons, then you cerebellum, then lobar. The fourth cause of a hypertensive bleed is lobar. So correct. He has got a hemiparesis, isn't it? He's dragging his right leg and right hand. So it is right basal ganglia. Okay. Big one or small one? Is it a big one or small one? This hypertensive bleed. The big one or small? Is obviously lost consciousness, right? So it has to be a big intracranial bleed. Otherwise, people will not lose consciousness. So you already have your diagnosis. He's got a big intracerebral bleed, probably in the left putamen or thalamus, that area. And that is why he has lost consciousness and his BP must have been high. That's why, because he forgot to take his BP tablets and he was about to vomit. So you got your diagnosis right from the history. So let me make you run through another problem. 30-year-old lady with some heart problem was running for a bus when she collapsed on the road. On arrival in the hospital, she was unconscious, did not move her right limbs. Sister said she used to have palpitations and breathlessness on walking and used to sleep on a chair some nights. What's the diagnosis? What's the diagnosis? Yeah? CVA. Okay, cardioembolic stroke, isn't it? It's a cardioembolic stroke. So obviously she's got a cardioembolic stroke. So what do you think is the reason for this? Palpitations, breathlessness on walking, sleeping on a chair. What is happening to her? She's got probably an atrial fibrillation. Possibly, we don't know. Okay, but it's a left-sided heart disease. Okay, and it is causing PND to her. That's why she's having this. It is probably causing some arrhythmia. We don't know. Sometimes you can get a volume overload, and because of that, also you can have palpitations. It can be an MR or an AR also. That we don't know. But definitely, she's got LV dysfunction, and she's got. You have to look for an atrial fibrillation. She has got PND, and she was running. She got an embolic stroke, and she did not move her right limbs. So she probably has a left cortical because she's unconscious. She's got a left cortical embolus, right? And probably because it's a big one and she lost consciousness and all. Where does this embolus usually go? Which part of the brain? Which part of the brain does it go to? Goes to a stem of MC, right? Stem of MC. So you see, you did not require much, okay? With this history, you made all your diagnosis. It's possible, okay? The 50-year-old chronic smoker with COPD comes with sudden onset severe breathlessness, right-sided chest pain. What is that now? What is that? Chronic smoker, sudden onset severe breathlessness, right-sided chest pain, pneumo. That's all it is. So you don't require much at all. It's a pneumothorax on the right side. It probably has an emphysema, not a core pulmonary. Sudden onset, severe breathlessness, tension, pneumothorax, right? So from everything, every part of that history, you can make a diagnosis, okay? Now I want to show you, yeah, 45-year-old man with fever with weight loss of 2 months duration. Since yesterday night, he has got 200 ml hemoptysis. So what do you think this is? What do you think this is? TB. Okay, TB. And it's a little more specific than TB. What kind of TB? What kind of TB is? No, it's not esophageal varices. It's got hemoptysis. So what is it? Pulmonary TB only. It's a little more specific. There are different types of pulmonary TB. There's miliary TB. There is a, yeah, it's a cavitation, isn't it? That's what I mean. It's not a fibrosis. It's not an infiltrate. It's a cavity. So you're obviously looking for a cavitary tuberculosis in this patient. Okay. So you went right up to that, right? You could make a diagnosis right up to that. That's what I'm trying to tell you. Okay. The last segment of this is where investigations do not give a diagnosis. Let's look at some problems where you did investigate. Investigation was negative. This is where we all get scared, isn't it? Otherwise, we are expecting everything will come out of an investigation. So let me look at this. 35-year-old lady came with headache of 2 months duration. She had a miscarriage 3 months ago and has had mood swings after that. She looks dazed, does memory lapses. Clinical examination normal, all systems normal. Okay. Biochemistry normal, MRI brain normal. She was put, this is one of my patients which I remember from Manipal. She was put on antidepressants, did not respond except she slept. What is the next step? Biochemistry is normal, MRI is normal. Now what do you do? She's got a headache of 2 months duration. Okay. She had a miscarriage. After that mood swing she had, she looks dazed. She has memory lapses. Clinical examination normal. There's no focal neurological deficit. Nothing is there. Biochemistry is normal. MRI brain is normal. What do you think she has? There is a clue in this that you're not picking up. What is that? Not SLE. Headache. Main problem is headache. I'll give you another clue. It's a CNS problem only. But your MRI brain is normal. Breast will have more of visual symptoms. She's not post-traumatic. She's not fallen from a bus or anything. She had a miscarriage 3 months ago. Okay. Yeah. Yeah. It is a cortical vein thrombosis. Okay. Now, this patient of mine, the only thing that was abnormal was her fundus, which nobody looked at. When I saw the fundus, I saw papilledema. Okay. No, because nobody asks for an ophthalmoscope, right? She didn't have a focal deficit. She had a big cortical vein thrombosis. The problem is the cortical vein thrombosis, unless it causes an infarction, may not cause any MRI changes at all. So you have to ask for an MRV, right? The clue came here because of this. There's a miscarriage. So related to a pregnancy. During that pregnancy only she got the cortical vein thrombosis, and after that she was been going around. She was told she's got depression, etc. But after the cortical vein thrombosis, when we put her on anticoagulation, she improved so well. She was much better when she came. So again, investigation, drawing a blank. Now this is again one of my patients. 25-year-old lady came with diplopia. She was watching a football match and everybody looked double to her. She became drowsy in a few hours. MRI was done, which was normal. Okay, blood work was normal. So everybody tried to do an LP on her. When they attempted LP on her, she woke up and became normal. Then she complained of headache all over the head. What is the diagnosis? What is the diagnosis? What is this? Pseudotumor cerebri? No. No, it came on when she's watching a football match, right? It's not going on for some time. She watched and she became normal. After that, she became normal. Pseudotumor cerebri will not reverse itself, right? So there is one rule in, yeah? Somebody said migraine. What migraine is this? What migraine is this? What migraine will cause a diplopia? What migraine will cause a diplopia? Basilar migraine, isn't it? This is a typical case of a basilar migraine. Okay. So this patient, see, one rule is there in neurology, isn't it? Or everywhere. Anything that is episodic is electrical or vascular. Correct. So electrical or vascular, remember that. It came, it went off. That means reverse itself on its own. So electrical or vascular. Can be a seizure or it can be a vascular episode. So this patient had a basilar migraine. One more patient I saw recently in Chennai also came with a diplopia like that. And she got very scared because everything was looking double. And then she became all right. And she did not know whom to tell also. So basilar migraine, the headache can come after the episode. After the episode is over, after the episode of whatever neurological deficit is over, then the headache can come. And these people respond extremely well to propranolol. So my patient here is also doing extremely well on that. So remember, MRI can be normal in that. So basilar migraine, only from the history, you're going to make a diagnosis. So what are the causes of MRI normal with a headache? Can you list the causes that the MRI will be normal and the patient has a headache? Severe headache, one is migraine. That we finished. Anything else? Okay. Okay, go on. Anything else? Cluster. Okay, go on. Anything else? There are many causes, isn't it? Some of them are simple, some of them are complex. But please remember, migraine is very important cause. Glaucoma in the elderly can cause Okay, cortical vein thrombosis, which I described to you. Temporal arteritis, like what we said. Hypertension, plain and simple hypertension, accelerated hypertension can cause headache. So remember, your investigation is not, okay, RCVS also can cause, it's a diagnosis, differential diagnosis for an SAH and can be missed on an MRI. Correct. Okay. So please remember that many of these things can be normal. Now look at this one. 60-year-old man with dyslipidemia with no other comorbidities get upper abdominal discomfort on climbing a slope on a road in Bangalore. He rests, feels better. Walks into a clinic, gets an ECG done, which is normal. Takes an ENO and sleeps off. What's your advice? What does this person have? He gets upper abdominal discomfort on climbing a slope, and then ECG is done, which is normal. Takes an ENO and he gets better. What's your advice? Why right-sided ECG? It's a plain and simple, stable angina. Plain and simple. Don't call it GERD. That's why I got this problem. It's a 60-year-old man. Okay. Don't call it GERD. When he's climbing a slope, he's not getting a GERD. Okay. Please remember that upper abdominal pain can be, angina can come from jaw to umbilicus. Remember that? Related to the climbing the slope. EEG normal because it's done at rest. So you have to think that you would go for a stress test and maybe an angiogram. So remember that investigations being normal never rules out. This is another one of my patients, 30-year-old lady with vomiting, vertigo since morning, no ear symptoms. MRI is normal. Okay. What is the diagnosis? Again, we have to take the history. Right. So this patient is coming vertigo, vomiting since morning, and MRI is normal. Remember that MRI can be normal in about 5 to 8% of posterior circulation strokes. Okay. Posterior circulation stroke, MRI can be normal, and you can completely miss. Whereas an anterior circulation about 1 to 2%. So just because the MRI is normal does not rule out a stroke. Okay. Please remember that whenever you're asking for the test, because we should know what gives, what doesn't give. Now, this is another interesting case. 65-year-old lady is admitted with vomiting and weakness and loss of appetite since 1 week. There are no other abdominal symptoms, no headache, no giddiness, no comorbidities. Clinical examination normal. Investigation showed hyponatremia and hypokalemia. What do you think it is? Actually, I forgot to give you the BP was low in this patient, but she had vomited. She had vomited many, many times. Okay, somebody is telling steroid. What is against a steroid withdrawal here? What is against steroid withdrawal here? This part, isn't it? The hypokalemia. We're not expecting hypokalemia in a steroid, the normal potassium, right? Okay. But this lady's potassium went down because she was vomiting. And yes, you are right about the steroid withdrawal. This is a patient we diagnosed recently. Patient had taken steroid for 2 to 3 years. She never told anybody. Okay. And for some illness, she had stopped about 2 weeks ago, came with an uncontrollable, weakness, hyponatremia, hypokalemia. We were thinking it's going alkalosis. We were thinking whether she has got a, Gittelman's, all kinds of things we did. Ultimately, we found that she was taking this. So again, this comes only from the history. Okay. So investigation without clinical examination, like fishing in the ocean for one fish. Okay. Just investigation without clinical examination. Clinical examination tells you where to fish. So once you get the history right, everything falls into place and then you can go. So the direction is always history and clinical examination towards investigation, not investigation. First you take out the MRI, then you look at the patient. That doesn't work. Okay. And remember what Osler said, if you listen long enough to the patient, he will tell you what is wrong with him. Many times you're not allowing him to speak at all. That is why you're not getting a good history. So I think we cleared our agenda. We are told why there is a history needed, what are the components, what's the importance of each, how to develop the skill, and will it surprise technology. I proved to you that you can make a diagnosis simply by history, and many times technology will not give you the diagnosis. MRI can be normal, your investigations can be normal. So let's learn to listen and make a diagnosis. This is from the Simon and Garfunkel Sound of Silence song. People hearing without listening. This is what is happening to us. We are not listening to the patient at all. That's why we are not getting the diagnosis. Thank you all for a patient hearing.
Yes, thank you, ma'am. I think it was apt what we needed. And I think two parts I would like to highlight. One is the 2 years headache can be a married guy. Possible.
That's
so, so we never know that.
What about
So
a married woman, Sanket?
I'm not sure. We have other differential there. Yeah. So, and I think a very important point, what as such we miss by giving exam or solving questions MCQ, which
Yeah.
I was little against, but it is needed. I agree with MCQ part. But in MCQ, examiner is making a case for you, and that's how we are
Yeah.
getting confidence that we can solve that case
Yeah.
of Gentleman syndrome or whatever it is. Okay.
Yeah.
The art is only about taking that history and making the case. So
Got
it's
it.
all converting patient's information to clinical symptom converting to clinical manifestation, and then connecting dots. That's
Yeah.
all. So
Yeah.
if we are good with MCQ solving, we may not be good with patient yet,
Oh.
till we can actually get the information. And very important point that anyone can do it, right? If I give these are the 100 questions you have to ask to a patient, even
Yeah.
AI can do that. What
Yeah.
matters is the inquiry pattern, because
Yes.
we have that background knowledge of being a physician. So
Yeah.
we know how to modulate and where to modulate. And
Yes.
that's what will keep doing us. I love the example of that cycle that, yeah, we have to do it more to
Yeah.
get it more. So that's the
Yeah.
only way. It's fun actually. At some point, it becomes fun to do medicine.
Yeah.
In residency, we don't feel it for first year, but then it becomes.
Yes.
Yes. Yes. Any question, any suggestion from anyone? More welcome. Okay, ma'am. I think then we should
Okay.
conclude. Yeah.
Thank
Thank
you.
you. Thank
Thank
you,
you,
ma'am.
sir.
Yes.
Oh.
Yes.